So we are proceeding with our program. And our next speaker is Professor Valérie Vilgrain from Congenital Hospital. It's her third time lecturing here in Israel. She was in a Latin hour meeting, she was in a FIM meeting, and now we are honored to have her in the Journée de Radiology, Israeli French here. Professor Bourgeon is the head of Bourgeon Department of Radiology, and she is the leading lady, the leading person and lady of liver imaging in France, and it's a very big pleasure for us to hear some facts in liver imaging. Thank you, Valérie.
Pleasure for me to be here, and again I'd like to thank Doris Village very much for your invitation. So my first lecture will be on pitfalls in liver imaging. Just before starting, I'd like to ask you one or two questions, because we may think that the liver is quite tricky. So do you think how many liver or livers do we get? 1, 2, or 3? What would you say? 3? What would be the best answer? Well, actually, we can think that we've got 1 liver, but it's not true. We have 2, the right one and the left one. Okay. And if we go a little bit in details, can we see the right and the left liver? If we look at outside the liver, can we see the boundaries, the landmarks? Yes or no? No, excellent, you are right. Because what we see is not the right and the left liver. We see here the falciform ligament, which separates the left lobe from the right lobe. So that's another reason to consider that the liver is very tricky. The boundary between the right and the left is invisible and is a virtual line between the IBC and the gallbladder. Okay, and my last questions. How many liver segments do we get? 8, 9, or 10? 9? 10? Well, actually, it depends. The classical answer is 8, and it has been described by Charles Bruno. But even himself doubted about that, because a couple of years later, he said that we should cut the caudate lobe between 2 pieces, the left one, which is really the segment 1, and the right one, which is along the IVC, and which is called the segment 9. So I don't want to go so much into details regarding liver anatomy, which is a topic I like very much, but have decided to focus on 3 different issues. The first one being that you know that all morphological changes in the liver are not related to cirrhosis, and I'd like to give you some clues about that. Let's see these 3 different imaging, patients A, B, and C. All 3 shows morphological changes of the liver. You agree? Which one is a cirrhosis? C, exactly, and only one. So, how can we make non-invasively the diagnosis of cirrhosis? Because the definition of cirrhosis is based on pathology. It's a combination of small, micro-regenerative nodules surrounded by fibrous bands. Well, any imaging can depict those internal changes. We can see here these small regenerative nodules that appear hypo on ultrasound here, and indeed the best imaging for showing cirrhosis is MR, and especially using T2-weighted imaging. This is one imaging finding for cirrhosis. Another one is to look at the morphological changes. And we don't still know exactly why, but some liver segments do shrink. And this is the case for the right liver and the segment 4, while others expand over time in cirrhotic patients. This is the caudate, so segment 1, and the left liver lobe. So this is very interesting. And as long as you see those morphological changes, then you can suspect cirrhosis. But if you see different morphological changes, then we have to think to other disease. And indeed, another very important finding, quite specific for cirrhosis, is the nodular surface. So by combining the changes in the internal architecture, the morphological changes, and the nodular contour, then you will be very confident in assessing whether your patient is cirrhotic or not. So what are the other diseases that can provide morphological changes of the liver? Actually, there are many different causes. First, biliary obstruction. Second, portal venous obstruction. And third, the hepatic venous obstruction. Let's start with the first one. This is a patient who had a couple of years ago a cholecystectomy, and as you can see, the liver has changed, was considered normal during the cholecystectomy, and what we do see today is a marked atrophy of the right liver. What is the reason for that? If we look a little bit in the details, we can see some small bile duct dilatation in the right liver. So actually, the story was during the laparoscopic cholecystectomy, there was an inadvertent ligation of the right hepatic duct, causing long-term biliary cholestasis and atrophy. This is a patient who had acute left portal vein thrombosis, and you can see here on the top, on the arterial phase imaging, increased enhancement in the left liver, which is the arterial compensation that occurs almost simultaneously to the portal venous obstruction. Okay, so no problem with the diagnosis. But if you look at the same patient who had a MR examination 6 months later, it is very interesting to see how the left liver has shrinked. Why such atrophy? Because you know that in the portal vein there are many things, hormones, and among them insulin, but also many nutriments. So it is really important if we want to have a liver growth to have a patency in the portal venous. So this is the second very important reason for that. And indeed, if you combine biliary obstruction and portal venous obstruction, you will get marked atrophy ipsilateral and marked hypertrophy in the contralateral lobe. The best example is represented by Hilar cholangiocarcinoma. Here, again, in this patient, marked atrophy of the right liver due to 2 reasons. Indeed, the cholangiocarcinoma, in this case, was developed more in the right hepatic duct than in the left, and associated with the encasement of the right branch of the portal vein that we can see here. So, indeed, very marked atrophy and contralateral hypertrophy. And the last very important etiology for atrophy or contralateral hypertrophy is related to hepatic venous obstruction. This is an example of a patient with the Budd-Chiari syndrome. This patient had obstruction of the 3 major hepatic veins, and you see here marked atrophy not only of the right liver but also of the left. So there is one enlargement of the caudate, and here you can see that actually we can divide the caudate between the left part and the right one, so the segment 1 and 9. And how do we explain that this segment not only remains stable in size but also increase in size? This is due to the very peculiar hepatic venous drainage made by multiple small caudate veins that directly drain into the IVC. So indeed, we have seen the most important mechanisms, but there are also diffuse disease that deal with the obstruction of small hepatic veins or small portal branches or small biliary disease. So this is quite an uncommon disease, the congenital hepatic fibrosis. But again, you can see important morphological changes of the liver with atrophy of the right and hypertrophy of the segment 4. So immediately we should think that this is not cirrhosis because we have seen different morphological changes. So my key message here is that all end-stage portal, hepatic venous, or biliary disease may show morphological changes of the liver. And here we have to look at additional findings, some bile duct dilatation here, and some other abnormalities, especially in the kidney, and then we can make the diagnosis of congenital hepatic fibrosis. So this was the first issue I'd like to discuss with you. The second one is whether a lesion is intra or extrahepatic. We may think it's a very easy task to differentiate and to find out the origin of the tumor. Actually, it's sometimes very, very difficult. I would like to show you these two patients, okay? Large lesions in the right hypochondrium. So do you think that both are intrahepatic, that both are extrahepatic, or only one is intra and extrahepatic? First thing, as I said, larger the tumor, more difficult the problem. So what kind of tips and tricks can we use to differentiate whether it's intra or extrahepatic? Well, there are several. First of all, try to figure out where is the center of the lesion. If it's outside the liver, definitely the lesion is extrahepatic. In these two cases, it can help because I think it should be in the right liver. Also, a very important finding is the tumor to liver angle. If you see some liver parenchyma that goes along the tumor, definitely the tumor is inside the liver. But same thing here, it's not easy. It is very important, especially in large lesions, to look at vascular landmarks. Where is the IVC? In place or not? And how are the portal branches? Are they normally oriented, or do you see any displacement? Okay? And then we have also to look at the organ displacement, and especially here, the right kidney, the right adrenal. Okay. So the answer is, this one is intrahepatic, while that one is extrahepatic. Okay. Why? Let me see that. If we focus now on the extrahepatic tumor, this is the right portal branch, while this is the left portal branch. It's quite an unusual orientation, because usually we should see that right branch of the portal vein and the left one. As soon as you see displacement between the right and the left portal branches, you should think at extrahepatic lesion. Another key finding, very important, is the displacement of the IVC that we could see here and was not seen on the other cases. But indeed, you need all the coronal reformation, and here you can see as well the displacement of the right kidney. So definitely, based on these imaging findings, we can say that the lesion is extrahepatic. But what kind of lesion is it? It was a cystic fibrosis. So you see how important are the anatomic landmarks, because indeed this patient was referred to our institution for treatment of large cystic lesions, liver lesions, and it was not at all the same diagnosis. Another example, in small lesions, we have here two examples, this one and that one. So if we try to assess where is the center of the lesion here, you can see that it's really at the border. So I would not say that this lesion is intrahepatic. It resembles to a lesion extrahepatic that goes within the liver. Okay. What about that one? Here we can see that there are some piece of liver that goes along the lesion. So this lesion is intrahepatic subcapsular, and actually it was intrahepatic splenosis in a patient who had a splenectomy for trauma years ago, and this one was an extrahepatic lesion. Okay. Then the third issue I'd like to see with you is it a true liver tumor or a pseudotumor? And unfortunately, it happens quite often because there are two big mimickers of liver tumors. The first one is dealing with the fat, steatosis, and focal fatty deposits or focal fatty sparing, and the other one which deals with the lesion enhancement. So if we start with the fatty lesion, let me again show you a case. Well, two different patients. On the top, patient A. On the bottom, patient B. Both patients had MR. This is in phase, and these are opposite phase. In both cases, we see here a drop in signal intensity. So here there is fat, and here there is fat. What do you think? Are these two patients, have they got tumors or not? Well, E it means on the top, is only focal steatosis, while B is a true tumor. It was a steatotic, the HNF1 alpha mutated hepatocellular adenoma. Indeed, it is very important. You will not manage in a similar way these two patients. This is only, I would say, abnormal variant, where this one with this large tumor may require at least patient management and discussion, and in some cases, surgical resection. So, if we want to go a little bit in detail with the focal fatty spheric and focal steatosis, first of all, it is very, very interesting, but there are some keys. First key is location. Okay, you won't see those abnormalities elsewhere in the liver. No, you will see them always near the hilar. So posterior aspect of the segment 4, okay, the left liver lobe, and the anterior part of the caudate, as well as around the gallbladder. Why? Because these focal fatty sparing or focal steatosis are related to abnormal veins entering the liver. So you can't imagine that there will be a abnormal vein in the middle of the right liver or in the middle of the left liver. Okay, so this is the first thing. Specific location. The second thing, which is the second key, is it has to deal with the portal veins and the portal vein tributaries. You know that the portal vein is mostly composed by the supramesenteric vein and the splenic vein. However, there are two small veins that directly drain within the portal vein. The first one being the right gastric vein, and the second one being here, the posterior duodenopancreatic vein. Okay, this is the normal venous anatomy. Unfortunately, these two veins, and it happens quite commonly, might drain directly in the liver. What could be the consequence? The consequence is very important because they are very different in blood composition. This one being very rich, insulin rich, because it drains the pancreas, whereas that one is insulin poor. So let me simulate with you abnormal venous drainage. And let's start with the right gastric vein, okay? This one, the right gastric vein, drains directly in the liver and usually in segment 4. So this would be an area with a low content of insulin. And in a patients with otherwise liver steatosis, this would explain, in most cases, the focal fatty sparing, okay, that we see, I would say, nearly every day. Okay. So, I don't know if at this point you trust me or not. If you don't trust me, I'd like to show you an example. This is a patient who was referred for a liver tumor. Indeed, there is marked steatosis, except the segment 4, which is well seen on ultrasound. We confirm the marked steatosis by showing the decrease in signal intensity of this imaging here, apart the segment 4. So, okay, we all agree that there is focal fatty sparing, but do we see abnormal vessel? We see abnormal vessel if we look for abnormal vessel. If we don't, we'll never get it, okay? So this is the same patient. What do we see on contrast enhanced imaging? A vessel. We usually never see a vessel entering directly segment 4. Segment 4 is supplied by the left branch of portal vein and the left branch of hepatic artery. And here we see a vessel. And we can see that the vessel is enhancing not on arterial phase imaging, but on portal phase imaging. And indeed, if we do a Doppler, we can see that it's a portal venous flow. So this is the example and the explanation of focal fatty sparing. Okay. And we can see this here. Now, if we take the second example, we have the right gastric vein in place, and we have abnormal variant of the posterior duodenopancreatic vein that again drain directly in the liver. Here, the blood will be richer in insulin, and therefore will cause plaque exactly at the site of the drainage. So this is the case I showed you before, okay? marked signal intensity here in the segment 4. Again, I want to show you that we can see the abnormal vessel, and this is the same patient on CT. Oh, it's strange. It seems that I can see a vessel here, and it's much better seen if I do maximum intensity per projection. And again, this is the explanation, not on focal fatty spreading, which is very, very common, but on focal steatosis, which is less common, but still very classical. So it means that, please, I'd like for you to remember that first location and then abnormal supply of portal venous tributaries might explain most of the uneven deposition of fat. However, there is still something that we do not understand: the mechanisms of pseudotumoral steatosis. These patients mimic multiple angiomas, steatotic hepatocellular adenomas, or even liver metastasis. You can see all these tiny, bright lesions in the liver. And again, the CT might show multiple hypoattenuating lesions that usually do not really enhance over time. Again, the key here is the MR, by showing nothing or in-phase imaging, but drop in signal intensity and post-phase imaging. This indicates that there is fat. But can we discriminate pseudotumoral steatosis from steatotic hepatocellular adenomas? Yes, I think we can. We can because these, in pseudotumoral steatosis, all these bright areas on ultrasound and are small size. I don't know why, but usually they are all below 1 centimeter. They enhance parallel to the liver. They will not be hypervascular, and for an unknown reason, usually even the border of this pseudotumoral steatosis contains more fat than the center. So based on that, you can conclude, without performing liver biopsy, that it corresponds to pseudotumoral steatosis and not steatotic hepatocellular adenomas. But again, the reason why we see that is still unclear. And last part, I told you that another way, other pseudo lesions might be explained by differences, by perfusion disorders, differences in liver enhancement. So I would like just to show you one example. This patient had no remarkable findings on unenhanced and delayed CT. So the only very striking findings were seen here on the contrast-enhanced imaging, where we do see differences between the central liver, which is here hypoattenuating, and the peripheral one, which shows marked enhancement on arterial phase imaging. Is it a tumor or a pseudotumor, and can we explain that? But before giving you the explanation, I'd like to define with you what are perfusion disorders or vascular abnormalities. They are the common findings, so the finding that they share is that they are rarely seen on an enhanced phase, and they usually predominate either on hepatic arterial phase or on portal venous phase, and they usually disappear on delayed phase. So this is very important. This enables us to differentiate the perfusion disorder from the true lesion. Okay. And then there are two very different mechanisms. The first one being related to portal vein obstruction. Here, we see on hepatic arterial phase imaging increased enhancement in the liver where there is a portal vein obstruction. And let me show you the example with the straight landmarks. So this is a patient with normal enhancement here in the right liver, increased enhancement here in the left one, related to portal venous obstruction. So we don't even need to see the portal vein obstructed itself, but we can make the diagnosis based on the differences in liver enhancement. Okay. And the second very different cause is related to obstruction of the outflow, starting from the hepatic vein to the IVC and the heart. And here, the vascular abnormalities are mostly seen for portal venous phase and have a very, very different aspect, usually called as reticular or mosaic pattern. and no very precise anatomical landmarks. Okay, so if we go back to our case, it doesn't really fit. We see a difference between the central liver and the peripheral one. Here the key is we are not dealing with obstruction with the portal vein, the right or the left one. We are dealing with the obstruction of portal venous trunk itself. And what happens in this case, very rapidly, I mean some days immediately after the obstruction, small veins, which are called portal cavernoma, will develop and will supply the liver with portal blood. But they are never large enough to cover the whole liver. So they will really be concentrated on the central part. And this is what the Japanese radiologists have called the zonal anatomy, differentiating the central liver, which doesn't correspond to any anatomical landmark, to the peripheral one. And again, on arterial phase imaging, the normal enhancement is in the center, and there is an increased enhancement due to the lack of portal perfusion in the peripheral part of the liver. And indeed, in this patient, weeks after, we could see very well the development of portal cavernoma. So let me now conclude. First of all, I have just picked up some of the pitfalls I considered important, but there are many others. I'd like to stress that morphological changes indeed are often seen in patients with cirrhosis, but they may be seen in other liver diseases as well. So please think to biliary, portal, and hepatic venous disorders. Second, dealing with the large tumors, whether they are intra or extrahepatic. Larger tumor, more difficult to assess the origin. And third, the two great mimickers of focal liver lesions are uneven deposition of fat and perfusion disorders. And only if you are interested in, if you want to see more examples, we have published recently the special review for residents in radiology that has come up in 2006. Thank you very much.
Any questions from the audience?